Professor Bagazzani. Sorry for the inconvenience, it was a technical problem. Chronic heart failure from clinical trials of combination drug therapy teach us we have to change a little bit our behavior attitude toward treatment of chronic heart failure patients. Using international guidelines and applying them to the economic and social context, for example, China. This has been done in cooperation between me, my cardiology department, the cardiology department of University Gemelli in Rome, Carlo Pappone, electrophysiology of San Donato, Professor Calò, and Professor Claudio Rapezzi, who is the chair of cardiology at the University of Bologna. All the information have been also compared with what is available in the most important book we are using today for drug therapy, even in China, the O.P. Gersh Drug for the Heart and the Goodman and Gilman Manual of Pharmacology and Therapeutics. I will switch all the slides for diagnostic approach to heart failure patient because this is something that is not part of this discussion. But the diagnosis of heart failure patient is an important issue. The definition of heart failure also with preserved ejection fraction, with mid-range ejection fraction and reduced ejection fraction is a very important subgroup identification of patients. I will switch that, but it's a very important role of cardiac imaging today in evaluating patients with suspected or clearly evident heart failure. What is important to know about heart failure, we should use also some prevention of some important cardiovascular disease like hypertension, chronic heart disease, valvular disease were responsible most of the time of heart failure in our patients. But what we know about drugs today, we know that ACE inhibitors or angiotensin receptor blockers or beta blockers or spironolactone or eplerenone and even isosorbide hydralazide association in the United States in black patients are able to reduce mortality. So this is a very important endpoint. Drugs who are able to improve symptoms according to clinical judgments are diuretics, nitrates, iron. You have to correct anemia also, in your patient with heart failure. And divabradine, as the speaker before taught us. Okay, which are the evidence-based medicine data on how to treat our patient from the pharmacological point of view? Just remember that if you are using only few drugs, you will not improve the survival of your patient with heart failure. If you use too many drugs and if you don't control their side effects and the interaction, you will get problems. You will get clinical problems and sometimes worsening of heart failure also. So there is a class 1 level A of evidence for ACE inhibitors. There is a class 1 A level for beta blockers and also for anti-aldosterone drugs. The success of ACE inhibitors in heart failure comes from two very important studies, the consensus and the SOLVE trial. They showed that in patients with ACE inhibitors, you can have a change in survival and improvement in reducing mortality and survival improvement. These are the comparison between the SOLT, the CBIS, which is including beta blockers, and the emphasis, which is the most important one, a new study including ivabradine and beta blockers, and on the top of an ACE inhibitors. The guidelines recommendation from our society, from the European Society of Cardiology, but also from the American College of Cardiology are the following one. An ACE inhibitor is recommended in addition to a beta blockers for symptomatic patient with heart failure and reduced ejection fraction, class 1 level A. A beta blocker is recommended in addition to an ACE inhibitor for patients with stable symptomatic heart failure and preserved ejection fraction. A recommendation for a mineralocorticoid antagonist is recommended for patients with reserved ejection fraction who remain symptomatic despite treatment with ACE inhibitors and beta blockers. So you already selected a subgroup of patients who remain symptomatic after association of ACE inhibitors and beta blockers, to whom you are allowed to add a mineralocorticoid antagonist. So patients with symptomatic heart failure with preserved ejection fraction class 1 and class 2A, able to tolerate ACE inhibitors, patient in sinus rhythm with an heart rate with a QRS duration of more than 130, you can switch them to non-medical treatment. But if the sinus rhythm, as showed before, shows an heart rate above 70 beats per minute, you can use ibavradine today. Ibavradine showed an 18% reduction in the mean follow-up of this patient in comparison to placebo, with a 26% reduction in hospitalization and 26% reduction in mortality, which means 1 out of 5 patients, 1 out of 4 patients. Ibavradine is not an alternative to beta blockers. So first of all, you have to use ACE inhibitors and beta blockers. My secret is to, as I learned from my clinical practice, is to titrate beta blockers, and sometimes it takes 3 weeks, 4 weeks to find the right dose in that patient. Should be a very slow process in increasing the dose of beta blockers to the most tolerated one in any given patient. It takes 3 or 4 weeks to find the right dose of beta blockers, which is tolerated by the patient and which does not give side effects. This is a study we referred before in another session. It's the study using sacubitril and valsartan together because they are blocking different pathways in heart failure patients. I'm sorry, going the wrong way direction. So the recommendation for IF channel inhibitors should be considered to reduce the risk of heart failure hospitalization and cardiovascular death in symptomatic patients with left ventricular ejection fraction below 35. Angiotensin receptor blockers, which is another very important class of drugs, is recommended to reduce the risk of hospitalization and cardiovascular death in symptomatic patients unable to tolerate an ACE inhibitors. So you're not allowed to use quadruple therapy, which means beta blockers, ACE inhibitors, angiotensin receptor blockers in the same patient. You are supposed to find a subgroup of patients who don't tolerate ACE inhibitor because of cough, for example. They can take still beta blocker, they can take ibavardine, they can take a mineralocorticoid agent like a eplerenone, and they can take ibavardine. So you still have a quadruple therapy for a selected subgroup of patients. The patient who cannot tolerate ACE inhibitors. The quadruple therapy may benefit some carefully selected patients, but renal dysfunction and hyperkalemia must be strictly monitored. If you don't want to deteriorate the kidney function, if you don't want to get the proarrhythmic effects or the side effects of hyperkalemia, which means the increased level of potassium in the blood, you should monitor accurately these patients. Otherwise, you will get less benefit and more trouble from quadruple therapy today of heart failure patients. This association has been proved of efficacy just in the black population in the United States. So it's not something that we can really use in Europe or in China. It's very useful for black population in the United States. The future will be gene therapy and stem cell therapy. In heart failure, there is a diminished and restricted flow of calcium ion inside the cell, and gene therapy aims to regulate the activity of SERCA, which is the sarcoplasmic endoplasmic reticulum calcium antipasy, could be a perspective in a subgroup of selected patients. Let me tell you the importance of titration time. It takes time to start a new therapy and to monitor it in patients. It's not something that will happen in a few days. It will take 1 week, 2 weeks, 3 weeks. But this is the best way to do the therapy in this kind of patient, avoiding side effects and avoiding complication. Start with the low dose of ACE inhibitors, 50 milligrams twice daily. Higher ACE inhibitors or angiotensin receptor blocker in alternative, and increase every 2 to 4 weeks to the target dose of 200 milligrams. So the titration time is an important issue in the management of this patient. There are some precautions. Don't discontinue ACE inhibitor at least 30 hours before starting valsartan. Stop them before. Do not combine with ACE inhibitors. Don't do together ACE inhibitors and our angiotensin receptor blocker or aliskiren. Hyperkalemia, reduce blood pressure, and reduce glomerular filtration, which is kidney function, should be carefully monitored in this patient. You should lose your patient not because of heart failure, because of the complication of multiple drug therapy. The very important studies show that the paradigm heart failure study showed that the primary endpoint, cardiovascular death, heart failure hospitalization, expanded composite endpoints are really modified by this association in comparison with enalapril. Enalapril is the second generation of ACE inhibitors. Don't forget to correct anemia in your patient. When you have less than 10 grams of hemoglobin, iron hemostasis is a relevant issue in these patients. And consider CRT, which is biventricular pacing stimulation, and surgery if needed. Don't forget, being a clinician, being a clinical cardiologist, we do a lot of surgery also in these patients, but we shouldn't forget that cardiac surgery is important, is crucial for valve diseases with heart failure, for valve disease patients with heart failure. But there is no significant benefit, honestly, between medical therapy alone and medical therapy plus coronary artery bypass grafting with respect to death from any cause in patients with coronary artery disease, left ventricular function, dysfunction. So the surgery could be relevant to reduce heart failure in patients with valvular disease, but couldn't be that helpful in patients benefiting from medical therapy. So let us use medical therapy, which is less expensive, which is something that makes our role of physician very important, because I told you the titration of these therapies and the monitoring of this therapy is very crucial and is very part of the competent physician behavior versus his patients. Okay, when to start this therapy? You can see that ACE inhibitors can be started at the beginning, just in class 1, in class 2, and it takes a few weeks, maybe a few days to get some benefit. On the contrary, you need some weeks to get benefit from beta blocker therapy. And then you can get the benefit from diuretic agents and the sparing and potassium sparing agents from the beginning. But let us again stress the point of monitoring and the titration therapy modalities for these patients. We saw this morning and this afternoon a very important Chinese study on comorbidities associated with heart failure patients. The three most important, at least in Europe and in America, are diabetes, chronic obstructive pulmonary diseases, and kidney failure. I was impressed. There is a very low incidence of diabetes in the Chinese heart failure survey and in the Singapore heart failure survey, because they enrolled many more patients with primary dilated cardiomyopathy than patients with coronary artery disease. And diabetes is a very important comorbidity causing coronary disease. When start each treatment? ACE inhibitor can be started from class 1 and class 2. Beta blocker should be started from class 2 and 3, and aldosterone blocker should be really reserved for class 3 and 4. Then there are some other associations, you can see them, and the time where they can be started. Maximal therapy for chronic heart failure patient should include quadruple therapy. But please don't forget to monitor these treatments because you can induce more side effects and benefits if you don't do that. Just a few recommendations. For ACE inhibitors, don't forget that the treatment is given to improve symptoms, to prevent worsening of heart failure, and to increase survival. These are the doses, the most frequently used doses of different ACE inhibitors. When you consider the difference between an ACE inhibitors and an angiotensin receptor blockers, think that ACE inhibitors possibly low efficacy in chronic administration because of an increased activity of CE. Favorable effect on survival, cardiac function, and hospitalization, confirmed in large controlled trials. For angiotensin receptor blockers, they are still lacking some good results for survival. So there are ongoing trials on survival in chronic heart failure patients. But we are still count on their effects in improving hemodynamics and cardiac function in these patients who cannot tolerate ACE inhibitors. These are the kind of drugs that are available in Europe, and some of them are available in China, obviously. These are the kind of beta blockers which are available in the United States and Europe, and some of them are available in China. At least I'm pretty sure about metoprolol, I'm pretty sure about carvedilol. I don't know about bisoprolol. Beta blockers. Beta blockers are important drugs, but not to be used in unstable patients hospitalized with worsening of heart failure. Please, there are still some contraindications to beta blockers in heart failure patients. If symptomatic improvement occurs with beta blockers, this may be developed in 3-6 months. So you need time to evaluate and to get the right dose of beta blockers in a given patient. And don't forget that you should use a dose by kilogram of weight in China, because the Chinese patients are smaller than the European patients, so the dose should be reduced. And then you can have a temporary symptomatic deterioration in beta blocker therapy, which occurs in almost 1/3 of the cases at the beginning of the therapy. For that reason, I was stressing the point of titration. Start with small dose each other day, and then increase the dose to the maximum tolerated dose of beta blockers. Finishing, not to stop a beta blocker therapy without consulting the physician. So please ask the patient not to stop the beta blocker therapy unless he has side effects without consulting his physician. These are the dose of beta blockers. A very important issue is the hypotension. Hypotension is a great issue in all clinical trials for heart failure patients. Beta blockers should not be stopped suddenly unless absolutely necessary. There is a risk of rebound increase in myocardial ischemia, infarction, and arrhythmias. Ideally, specialist advice should be sought before treatment discontinuation. There is no time for digoxin. Digoxin is another very important drug in heart failure. And these are the non-pharmacologic treatment, which is not an issue for today, but you still have a role for non-pharmacologic treatment of heart failure patients. In conclusion, I think today heart failure patient treatment requires a very deep understanding of the mechanism of each drug action in a given patient, in a subgroup of patients, and you should really be able to follow these patients during titration of therapy and monitoring the effects of this drug during long-term therapy. This is the secret in my clinical practice. Thank you for your attention.